Friends, welcome back to my channel with the new video on arterial blood gas interpretation. And again I have divided into two parts. uh, this particular talk was combinedly taken uh, at the workshop organized at the recent annual National ICCM conference organized in Kochi. I would sincerely thank my colleague, Dr. Meenal Zariwala, consultant intensivist at Max Nanavati Hospital, Mumbai, for the slides and for the help. So, without further ado, let us start. So, as far as arterial blood gas is concerned, remember whenever you see a ABG like this, it is extremely important to mention the FiO2 on that particular report, or you should be aware of how much was the FiO2 on which the arterial blood gas is taken, and then that makes it relevant than without putting an FiO2. So this is the first opening statement which I want to kind of say. Now after that, as we know, pH, PCO2 and PO2 are the measured values, and the bicarbs and the saturation are the calculated value. So these are the reference ranges for your ready reference, right? So don't forget to mention the FiO2. Now it has to be with the clinical correlation. No test in medicine or in intensive care is without any clinical background or the context of the clinical findings which that particular patient has. So for an example, the measured values like starting from pH, which actually denotes the acid base assessment, and of course the PO2 and PCO2 will actually give us information about the respiratory assessment, and both combined with clinical evaluation can give us the complete assessment. Correct? So this is important. Now the first step according to me would be the validation of the ABG. So it should be assessed about the internal consistency of the values using the Henderson-Hasselbalch equation, which goes by the H ions is equal to 24 multiplied by the PCO2 divided by the bicarbs, right? So this, remember this equation, and where H plus we can also derive it with the formula of 80 minus the last two digits of the pH. So for example, it is 7.30. So you need to actually 80 minus 30 becomes 50. If it is 7.20, it will be 80 minus 20 would be around 60, and things like that. Okay, so this we need to tally, and we'll look at it with the help of an example. So if the pH and the H plus are inconsistent, the ABG is probably not valid. So here we are looking at a pH, and here we are looking at the H plus ions. So we'll see how it goes. So now in this particular ABG, if you see, the pH is 7.30, PCO2 of 26, PO2 of 105, and bicarbs of 22. So with that formula, the H ions will be 80 minus the last two digits of pH, that is 30, so it becomes 50. And we need to calculate the H plus with this Henderson-Hasselbalch equation by the formula 24 multiplied by the PCO2, that is 26, divided by the bicarbs, that is 22. It comes to 29, and these two figures does not tally. So that is why this particular ABG does not validate, and it is inconsistent. The simple things to remember in this Henderson-Hasselbalch equation is lung is above the kidney, so 24 multiplied by the lung divided by kidney, and lung is PCO2 and HCO3 is kidneys. So this is easy way to remember. Now this is the ABG for the validation practice. As you could see, pH of 7.42, PCO2 of 38, PO2 of 105, and bicarb of 34. So if you actually tally these two, they are actually, if you see that, they are not tallying. So probably the above ABJ is not consistent or valid. And if you look at the second example of pH of 7.35, PCO2 of 47, PO2 of 67, and bicarbs of 24, 25.4, and then if you see, they are almost tallying. So H plus 80 minus the last two digits, and Henderson-Hasselbalch equation 24 multiplied by the lung, that is PCO2, divided by kidneys, that is bicarbs. So the above one is not valid, and the below one is valid. So talking about some technical errors, that the PO2 drops by about 5 millimeters of mercury for every degree below 37 degrees. PCO2 drops by about 2 millimeters for every degree below 37, and pH increases by about 0.015 for every degree of below 37. Remember, if the delay is more than 10 minutes, the specimen must be immersed in ice bath, and it can cause significant fall in PO2 over the period of time. So as we know, ABG is a point of care test. You should have a ABG machine in each and every ICU so that you don't waste time and there is no spurious readings as far as PO2 is concerned. Air contamination of a sample can dramatically alter the reported PCO2 and PO2. Both will move towards the value of PO2 and PCO2 in room air. So for an example, if the patient's real PO2 is 250, the measured PO2 will fall toward room air PO2, which is about 150. So alternatively, if the patient's PO2 is really 60, then the measured PO2 will rise towards 150. And excess heparin can actually tend to decrease the pH. So these are few of the technical errors which anyone should be aware of. And let us start from the steps for the successful ABG analysis. Right from the history, the thing can replace a good detailed history, relevant history, and with the aim of assimilating that information into the analysis of ABG. Look at the PO2 for hypoxemia. Calculate the alveolar arterial oxygen gradient. Check for the validity. Look at the pH and make sure who is responsible for the change, or in other words, what is the primary disorder. If there is primary respiratory disorder, whether it is acute or chronic and things like that, and we'll deal with it in short while from now. If disturbance is metabolic, then what is the appropriate respiratory compensation for the same. Calculate anion gap, delta gap, and urinary anion gap, and we will see one by one. So assessment of the oxygenation status, as we know, hypoxia is fatal. Look at the PO2 and the saturation. Of course, the PO2 by FiO2 ratio or the PF ratio. As we know, the normal room air FiO2 is 21%. So normal PO2 becomes, which is 5 times the FiO2. So normally it will be around 100. Alveolar arterial oxygen gradient is given by the equation of PaO2, that is the capital A, minus PaO2, that is small a, and it is between 0 to 10. And what is the alveolar oxygen? It is given by the formula FiO2 multiplied by the difference between the barometric pressure and the water vapor pressure, minus PaCO2 divided by 0.8, then that is the respiratory quotient. So normally if you put all these figures like FiO2 of 21%, normal barometric pressure as 760, water vapor pressure as 47, PaCO2 of say 40, and 0.8 as the respiratory quotient, which is the constant. So the normal arterial O2, PaO2 is around 100, and the gradient between the PaO2 and small PO2, that is arterial, should be between 0 to 10. Now this is a flow chart which gives you the ventilation status of hypoxic patient. So if the PCO2 is high, then we are looking at nothing but hypoventilation. So if the PCO2 is high, we are dealing with something called as hypoventilation. And if the the PO2 by the PO2 minus PO2, that is alveolar arterial gradient, is increased, then you have a hypoventilation plus some another mechanism. Whereas if the PaO2 minus PaO2, that is alveolar arterial gradient, is not increased, then there is hypoventilation alone. And we will come to that as to what are the reasons for the high PCO2. So this will cause high PCO2 with hypoxia, that is respiratory muscle drive, decreased respiratory muscle drive or neuromuscular diseases. And of course the other reasons of hypoventilation plus another mechanism in a patient of the alveolar arterial gradient where it is increased. So the first step of assessment of hypoxia probably is whether the PCO2 is high or low or normal. So if it is increased, then you go to this hypoventilation arm. There you need to see the second step of alveolar arterial gradient, whether it is increased, then it is hypoventilation plus another mechanism. If it is not increased, then it is only hypoventilation. Understood? Now if there is a situation of hypoxia without PaCO2 increase, then also you need to see the alveolar arterial gradient, and if it is increased, whether the PO2 is low correctable with O2, whether there is a response of the supplemental oxygen to the low PO2. If it is yes, then it is VQ mismatch, which is classically seen in COPD, asthma, ILDs, alveolar diseases or pulmonary vascular diseases. If the oxygen or the PO2 does not respond to supplemental oxygen, then it is probably a shunt in the form of either atelectasis or a pneumonia or pulmonary edema or intracardiac shunts or intrapulmonary shunts. And if the alveolar arterial gradient is not increased, then it is probably a problem of decrease in the inspired PO2 in cases like high altitude or decrease in the FiO2, where you need to actually just increase the FiO2. So this is in short, in a nutshell, how we need to approach a hypoxic patient. Now let's look at the pH. So we have validated the ABG, we have taken the history of the patient, we know what is the primary steps as far as hypoxia is concerned. Now let us look at the pH. If it is less than 7.35, it is acidemic, and if it is more than 7.45, it is alkalemic. So this is probably very easy. Let us go to the next step. So who is responsible for the change, or in other words, what is the primary disorder? So looking at this, if the pH is acidemic and if the bicarbs are less than 24, then this is primary metabolic. Whereas if it is pH is acidemic and the PaCO2 is more than 40, then it is probably primary respiratory. Similarly, if the pH is alkalemic with bicarbs of more than 24, we are probably looking at a condition which is primary metabolic. And if the pH is alkalemic with PaCO2 of less than 40, then it is probably primary respiratory. In other words, if you look at this, very simple step or a hint which I need to give you today is look at the pH and the bicarb, and if these two are going in the same direction, either low or high, I'm sorry, this is the primary metabolic disorder. I'm sure it is not very difficult to understand. Whereas look at the pH and PCO2, and if they are going in opposite direction, then the primary disorder is respiratory. I think this is a very important and a vital kind of hint which anyone can get if we want to analyze or kind of interpret an ABG. So if pH and a bicarb are moving in the same direction, either high or low, then it is primary metabolic disorder, and if pH and PCO2 are going in opposite direction, then it is probably a respiratory disorder. So I think, my friends, that's all for now. We will meet in the next video for the part 2 of arterial blood gas, and let's meet in the next video. Tata, bye bye, take care.